This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon with practices in Midtown Manhattan and in Wayne, New Jersey.
I'm Marina Kurian. I'm a general surgeon that does a lot of minimally invasive surgery and weight loss surgery in New York City. And welcome to the show. I was just double checking with Suja before. This is our 54th show.
Yeah. Lucky 54.
Everyone says.
October is officially Breast Cancer Awareness Month. And today's show features two wonderful guests. We have Meg Kinnard, who is an AP Associated Press politics reporter and, in fact, a breast cancer survivor. And we have Dr. Peled, who is a breast and plastic surgeon, co-director of the breast cancer program at Sutter Health in San Francisco, and she is also a breast cancer survivor. We're going to talk about the fact that breast cancer affects 1 in 8 women and a small but significant percentage of men. So this is a great time to raise awareness, get your mammogram, keep yourself safe.
Absolutely. I think it's so important to go. I think we were talking about the show, Situ and I said, it's the mammogram is not fun. Not something. So my subconscious brain was like, no, you just did it. And I was like, oh, I don't think I'm due. And then, so I did have a gap and I thought, oh, maybe it's like 1.5 years or something, 3 years. I was like, whoa. So not recently. Now I've been much, much better about it. And I go every year.
But even in COVID, I think people just, we've talked about this for over 1 year now. People have really neglected sort of the general physical exam, self-care. Go get your breast squished between 2 metal plates, as Marina put it so eloquently.
Yeah. I mean, why couldn't they figure out a better way? But that's it. It's very medieval, I feel like. Anyway, but we'll talk about that with our guests. But guess what? Guess who's still talking COVID? Us too. Yep. And there's a few reasons why. I mean, now, the FDA has looked at booster shots. And so we want to talk a little bit about that. We want to talk about what's been in the news about the Pfizer vaccine and how long does it give you immunity. And so there was 2 studies that were published, and one was from Israel, one was from Qatar, and published in the New England Journal of Medicine, that you still need to maintain some precautions. And what they showed in the study from Israel, which was looking at 4,800 healthcare workers, that the antibody levels wane after 2 doses. And interestingly, especially among men, people 65 and over, and also people with immunosuppression. So these are people who should be getting a booster shot. And I think, there are models out there looking at what we should be expecting with this, I don't know, around the 10th round of COVID?
Yeah. I mean,
whatever it is, whatever wave this is, that there's some modeling out there that says maybe we'll be done with this by February or March.
So I hope so. I think, the good news is those of us who are vaccinated, we are much less likely, hugely less likely to get serious or severe disease. We're also much less likely to be infectious, to have enough virus in the back of our nose that we can pass it on to other people once we've been vaccinated. But the booster seems to be correct at about 6, 7, 8 months after Pfizer. We don't know yet about Moderna. So I got Moderna and I'm not up for a booster yet. How about you, Marina?
Oh, I went and got the booster for Pfizer. Absolutely. And, while we're talking about there, the reason to do it, as you said, we can be infected with the virus. I'm still, masking when I'm out, when I'm inside, if I don't know, obviously if we fly. But I still walk around with my mask when I'm walking my dogs, because in my building, we're supposed to wear it in any closed quarter. So I just walk around with it. I've almost gotten, unfortunately, used to it.
So, we are live on Facebook, on YouTube, on Twitter, on Sri Srinivasan's LinkedIn. Will be carried on WBAI.org and WBAI 99.5 FM Monday from 2 to 3 p.m. Eastern. And we have a podcast. So in case you just can't get enough of our dulcet tones, you can listen to us while you commute or work out, wherever you get your podcasts. We have people checking in. AJ Nathan, who was one of our guests in June, says hello from Mexico. Anne Arriaga says she's tuning in from New Hyde Park. Great topic. I agree, Anne. Sandra Lefkowitz says she's tuning in from gloomy Glen Ridge. It is overcast here in the Northeast, but we're so glad you guys are all joining us. We've talked about vaccines, and we see that the vaccine mandates are working. We see that healthcare workers who've been mandated to get vaccines are in fact getting vaccines, which I personally think is a very positive benefit for patients.
Yeah, I agree. And however, some people haven't. And even one of the largest healthcare consortium in the Northeast is Northwell, and they actually, fired 1,400 employees for not getting the vaccine. But what that slide that just popped up is showing that in a Louisiana health system, which is Auctioner, they are planning on increasing the insurance fees of any employees with unvaccinated spouses. So this is something that, I think many health systems are looking at because of the effect of it. Not just on, this is a privately insured company. So it'll be interesting to see if that translates in to other insurance companies and employee healthcare plans.
Yeah, the people who cannot get vaccines are still children under the age of 11 in the United States. So the rate of COVID is higher in children than in adults in August of 2021. And this is because they can't get vaccinated, but we're all sending them back to school. So this is vitally important. If you are 12 or over, please get vaccinated, because it really protects you. It protects your loved ones. It protects your community. It even protects people you don't like, which is fine as a human. We have Mona Nanavathi watching from Germany. Good morning, Mona, or good afternoon. We have some non-COVID news, Marina, before we get to our wonderful guests.
Yeah, something so cool. Suju found this. I did not see it. It is, a sign of change, which is a positive change. We have in the U.S., there is the changing of the guard at Arlington National Cemetery, and for 84 years this has been going on. And last month, for the first time, it was carried out by 3 women. So it is something that when we go to DC, we all go to watch it. It is really moving. It is emotional for all of us in the U.S. And it's so interesting. I'm glad that it happened. Thanks for finding that. I thought that was lovely.
Yeah, well, last year, this time, we celebrated all the women in STEM who got Nobel Prizes. And unfortunately, not a single Nobel Prize in science, technology, or math went to women this year. So congratulations to the winners, and maybe we'll do better next year.
Well, now we can go to our guests. We promised a show. We're doing a great show on breast cancer for Breast Cancer Awareness Month. But it's also so important because we have 51% of the population, and this affects so many people, on both men and women, because you might have a loved one that has breast cancer. And our guest today to talk about that is Meg Kinnard, a politics reporter for the Associated Press, and she's a breast cancer survivor, and also Dr. Anne Peled, who's a breast and plastic surgeon co-director of the breast cancer program at Sutter Health in San Francisco. And she is also a breast cancer survivor herself. And so welcome to our guests. Thank you so much for joining us.
Thanks for having us.
Thank you for having us. It's great.
Oh, it's so nice to see both of you. Marina and I were talking. The most fun part of this show for us is we get to meet really smart people and enjoy an hour with them. So thank you to our viewers. We are live on Facebook, YouTube, Twitter, and Shree's LinkedIn. Please send in your questions for our amazing guests, and we'll get to as many as we can. Let's start with how many people are affected by breast cancer. So, Anne, maybe you can talk to us about the demographics. Who gets breast cancer, and why is the incidence of it higher now than it has been in the past?
So when we think about numbers, we talk about 1 in 8 women being diagnosed with breast cancer. And if you think about it, that's actually a huge number. So pretty much, everyone is going to know someone who's affected by this. So I'm so grateful that you have us on today and that people are highlighting this issue, just because it really does affect everyone. I think when we think about kind of increasing numbers, one of the things that's been a wonderful change actually is that the more screening we do, the more breast cancers we pick up, but the earlier stage they are and more treatable. So when we look at certain areas of the country where they have really high rates of screening, we see a lot of breast cancers, but fortunately, a lot of those are picked up at an early stage. So this is one of the things, I know Meg will probably mention this as well, but we both feel really strongly about going in, getting those very painful mammograms, but doing it nonetheless and making it happen. So hopefully we can pick these things up at an early stage when they're really treatable.
I think it's really telling, right? It says 1 in 8. Suju and I went to med school when it was 1 in 11. So, I think it is those finding it at earlier stages and things like that is important. And the imaging is even better, even though the technique, as we already mentioned, is slap them between 2 cold plates. I'm like, can't you warm up the room? Something? No, hang on. And they crank this thing down. I'm like, actually, I can only, I can't, but it is so important for people to go. And once you're done, it is like a little sense of accomplishment that you went through it. And, and hopefully the report is, good. But you guys both went through this. And can we talk a little bit about that? Meg, can we talk about how it came to pass, or is it just like a routine mammo? Can you just tell us a little background about how you came to your diagnosis?
Of course. I ended up finding something myself in about 2017. At that point, I was not 40 years old yet. I was not in the regular routine of getting mammograms regularly, but I went and I requested one, and I was told at that point that what I had was a calcification, something that would likely go away hormonally, cyclically, but it wasn't anything to worry about. It felt kind of like a small pebble to me in my left breast. And I continued to do follow-up screenings every 6 months, every 12 months. Doctors kept looking at it, kept saying, this is fine. It's not really a big concern to us. We'll just keep monitoring you. My breast began to get very painful and to become red and swollen. All hallmark signs I now know are part of inflammatory breast cancer, but I didn't then. And my doctors told me that they felt that it was still okay. And so when I went back for another one of these follow-ups this past February of 2021, so this is almost 4 years into this process, a radiologist finally ordered a biopsy, and I was diagnosed with stage 3 invasive ductal carcinoma at the time. At that point, that was the last thing that I obviously wanted to hear, but was also incredibly shocking considering how long I'd been on this journey of being told that everything was fine. What I ended up doing, and I know it's different for every woman, but for me, I sought a second opinion because, and we can talk about this later in more depth if you all want to, but to me at that point, my husband and I decided this had been a 4-year process already of knowing that something was going on and not really having a diagnosis to go along with that. And he ended up Googling, what's the number one cancer center in the country, and came back at that time with MD Anderson, which is located in Houston, Texas, which is where I am right now because I'm still undergoing active treatment here. But to me, that needed to be part of my process as well, given how long everything had been going on without an actual diagnosis. When I was able to get here to MD Anderson, I was diagnosed with inflammatory breast cancer, which, as you all, as physicians, I'm sure are aware, is the rarest and most aggressive form of breast cancer. It represents only a handful of a percent of all cases. Thankfully for me, all of my treatments have gone well, but a large portion of that, and something that is very important to me that I talk about, is I know how fortunate I am to have been able to seek that second opinion and to have been able to come to a leading cancer center in the country for treatment that I know has been different than what was prescribed at my home hospital. And I'm told here by the doctors that this is really what I needed to have in order to have the best possible chance for a good outcome. So this has been a very a long journey for me, a very difficult year, but I know I'm in good hands, and I'm very thankful that I've been able to avail myself of some of the best services in the country. And I'm determined from this point forward really to do everything I can to pay that forward and to try to make coming to places like this and to get this level of care an option for more women, because not everyone can do what I did and drop everything and kind of move to Texas for 3 months and go back and forth. So that's something that is top of mind to me as I'm wrapping up my active treatment here.
Wow, I mean, what a story! And it's dreadful for us clinicians to hear that, you were actually on top of all of your follow-ups and everything, and that the diagnosis was missed. It's like it's all of our personal nightmares, right? Just even as a patient, but as a clinician, it's very hard to hear that. But I'm glad that you specifically went for that second opinion. I always encourage patients that they should seek another opinion, especially when we're talking about something that's rare or unusual, because it is so critical to that process. And I mean, tell us a little bit about your story, but I'd love to hear your thoughts on Meg's journey as well.
Yeah, I mean, I think, to start with Meg's story, I think it is such a good example of how important it is that we advocate for ourselves. And, the physician part of me wishes that patients didn't have to advocate so hard for themselves sometimes, and that they could bring something up and they would automatically be addressed and they would get all the care they need. But unfortunately, I know as a physician and as a patient that doesn't always happen. And so I think Meg's story is really, truly inspiring, but also really helps others thinking about, if you feel something, if you're worried, if you think you need more information, go get that second opinion for sure. Go listen to your body, listen to what you need, because ultimately, I think, Meg, you've done a really beautiful job of making sure that you are getting all the care that you need. So you're going to do really well from all of this. So, for myself, I think it was kind of a similar story in terms of knowing something was a little off when I was younger. I was 37 years old. I felt a breast lump. I tell my patients, don't be home worrying about breast things. If something is there and it doesn't go away, you got to get it worked up. And so when it was still there 2 weeks later, I had a biopsy, and I remember I was about to scrub into a big mastectomy and implant reconstruction surgery. And I saw the call from the pathologist and thought she was going to tell me it was a cyst, and picked it up, and she told me it was invasive cancer. And, I think that shock, that disruption, that what am I going to tell my family, actually come from a family of breast oncologists. So my dad is a breast medical oncologist. My mom and sister are breast radiation oncologists. My husband's a surgeon. So, it was a lot figuring out all those pieces, but I feel really lucky to have had early stage breast cancer. I am over 3 years out now, doing great. I actually many days forget it happened, which is incredible. So I feel like I'm in a really good place now to be able to help advocate for others, to remind young women, if you feel something, get it checked out. Don't let people tell you you're too young for breast cancer. I take care of patients in their 20s, unfortunately. And I think a lot of times younger women don't get their concerns addressed because people think breast cancer is something that only affects older women. So again, feel very fortunate to be in a place to be able to help others and advocate for themselves the way that I was able to advocate for myself.
So there's so much to talk about just in that little segment. One is you held it together to help another woman through her breast cancer journey right after getting that diagnosis. You went forward and scrubbed in, or which is operated on, to remove a breast and to remove the lymph nodes. We have couple of anatomy graphics just to show people what is inside the breast. So we see that there's, the nipple and the structure of the breast that you see from the outside, but there's other things going on. And when you say you had to do a mastectomy, which is removal of the breast, and a lymph node dissection, what does that mean and why do you do it, Anne?
So basically, there are two kind of main ways we treat the breast for breast cancer, which is either to do a lumpectomy, where we just remove the tumor and some clean tissue around it, or a mastectomy, where we take all of the breast tissue and leave typically the outside skin and sometimes the nipple, but it really depends. In some cases, we can't do that safely. And whether or not people choose to have a lumpectomy or a mastectomy has a lot to do with the cancer. It has to do with breast size. It has to do with people's family history and their genetics, and then also their personal decisions about it. So certainly that ends up being a very nuanced discussion that's very individualized. But we also sometimes need to take out some lymph nodes. And we want to know a couple of things. One is, has the cancer spread to the lymph nodes? In which case, maybe we can just do a biopsy and take a couple of those lymph nodes out. We have this discussion of what we call these gatekeeper or sentinel lymph nodes. That's kind of the first line of defense before tumor could spread to the rest of your body. So we check those lymph nodes and see if it has spread. Sometimes we know that cancers tend to be more aggressive, that they may have spread to the lymph nodes already, in which case we actually need to take more lymph nodes out to really make sure that we're not leaving any cancer behind. So these techniques have really evolved a lot to where we're trying to do less lymph node surgery when we can, but also make sure that we're doing everything we can to make sure we're not leaving tumor behind.
So you had made a little mention of it, Anne, in your discussion about risk factors. So we have a graphic up that looks at what a clinician is thinking when, we're talking to a patient that may have, breast cancer risks that are greater. Like you said, don't let anyone tell you you're too young for breast cancer because, as you said, you've seen patients in their 20s for it. So let's just go through this slide a little bit. And then Meg, if you can, let us know if did you have any family risk factors?
So, I think the first thing I will say, and I think it's good for people to hear this, is that most people who get breast cancer don't have family history or genetics. So certainly that was my story. I didn't have anyone in my family who had breast cancer. And again, I bring that up because I don't want people to think, oh, I don't have anyone in my family with it, so I won't get it. So most breast cancers are not familial, but there are things that can increase your risk. So for people who have had a biopsy in the past and been told that they maybe have atypical cells that aren't cancerous and are sort of on the borderline of precancer, that can actually increase your risk in the future. There are some factors related to kind of what we call reproductive factors. So people who have pregnancies later, people who have start their periods earlier or go through menopause later. Oral contraceptives, so birth control pills and hormone replacement therapy can also increase risk. And then people with denser breasts, and breast density is a whole big issue in of itself. We can kind of see if we get into or not. But these are some of the factors that we think about. We do know that family history, if you do have a significant family history, not just of breast cancer, but also ovarian cancer or even other kinds of cancers, it is incredibly important to talk to your doctor about getting a referral or doing genetic testing. One of the things that I find incredibly powerful in my practice is taking care of people who know they have family history, they get tested, and they're able to take this incredibly powerful and brave step of having risk-reducing prophylactic mastectomies to try not to get breast cancer. And that's a true example of knowledge is power. If you know that you have this risk, you're able to actually intervene and do something. And I tell people all the time, if I had known a year before my diagnosis that I could have done something about it, I would have in a heartbeat. And so it's really wonderful to see people who are taking that step so that they can do something about their risk.
So for people without a family history or any of the other risks that you talked about, sort of delayed child birth or long-term use of oral contraceptives, etc., what is the correct age to start your routine screening mammography?
40. So there's always controversy back and forth, but all of the big organizations that really take good care of women in our societies all recommend starting at 40.
And then, Marina and I were talking when I was a young warthog, right? When we were young kids, we were told to do breast self-exams. And I know that's fallen out of favor because people are driving themselves crazy identifying things, but we've both heard your stories. What should a younger person do if they feel something, or should they do it? Or, what, as you know, we know our bodies, but what's the right thing to do? And maybe I'll direct this over to Meg.
Well, certainly when I first began experiencing my own healthcare journey with what became my breast cancer, that started during a self-exam. So for me, that had already been something that was part of my monthly routine, which is what we were all told we were supposed to do. What also ended up developing, though, the cancer that I have specifically, inflammatory breast cancer, is not always associated with kind of lump. There are other telltale factors, such as a red dimpling of the skin, enlarged, swollen feeling in the breast, sometimes a discharge or an inverted nipple. Those are all things of which I was completely unaware. I don't know about Anne, but she certainly has a more in-depth understanding of breast cancers than just about anybody. But I didn't even know there were different kinds before I was diagnosed. So not only was I not aware of some of the symptoms of what ended up being my breast cancer, but I didn't even know that there were different types to be on the lookout for. So I think an overall just increased awareness for women of, okay, you've heard this thing about self-exams and lumps. Let's not even just focus on that, but let's think about other ways that you can be aware of your body. Do you feel that your lymph nodes in your armpits feel a little bit bigger than you remember than before? Is there soreness there? Is there a discoloration of your skin? All of those things accompanied my cancer, but I wasn't really aware of what I should be looking for. Part of the treatment that I've received here at MD Anderson and the diagnostics did include genetic testing. So I now know that I do possess one gene that's associated with about a 10% development of breast cancer and also colon cancer. That's good for me to know. It's good for my family to know. And as Anne said, if I had known that I had a gene with an increased risk factor before my diagnosis, that certainly would have given me information to arm me with, what should I be doing next to, plan along in my treatment, or perhaps a version of what's to come. I don't have a strong family history of cancer. So that wasn't something that was even on my mind. I do come from a family of doctors. Both of my parents are physicians. One of my uncles, great-grandfather, great-great-grandfather. So there's a lot of medical history in my family, and perhaps a little bit elevated awareness of what's going on with my body and my health because of that and our dinner time conversations growing up. But, all of that goes to say there are so many different kinds of things to be on the lookout for. And we as women, we can't just say, okay, check it off this month. I have, done a self-exam in the shower. Even if that were to remain a recommended thing that we all do, there's so much more than that. And so what I've learned in this process is the impetus really is on us to arm ourselves with all of that information. Because like I said, I respect all doctors. And I think that what you guys do for us as patients is amazing. And I've had so many physicians go above and beyond during my journey, but we're all still humans. And so on this side of the fence, for me as a human, I now feel that it's my job as the patient to really know as much as I possibly can, not just about breast cancer, but about other health things that I should be on the lookout for. And I really think that, we as women need to encourage each other to arm ourselves with all of that information just so we can be our own best advocates and really ensure that, okay, I've been to the doctor and this is what they say. I'm going to make sure that, you know, all that matches up with other things that I've read from reputable sources, or, you know, stuff that I've researched on my own.
That was such a thorough answer, Meg. Expect nothing less from a reporter. That was really great. But I want to show our viewers a little something about how these cancers can progress. And I think, you know, while this is specific for the breast, it is actually a great graphic for looking at how many cancers start in a cell and how they get bigger, et cetera. So, Anne, do you want to just touch base a little bit on this one?
Yeah, I think it's really key for people to see this progression, just to know if you do have, we were talking earlier, Marina, about abnormal mammograms and calcifications. And if you get a biopsy, you know, what does that mean if they tell you that they are atypical cells? And I think it's important to see that this is a progression. So we talk about many breast cancers do develop in the breast ducts themselves, which are what takes milk from the lobules, which are those little pink balls, and then go out in the ducts to deliver milk to the nipple. And so we sometimes have these biopsies that come back with atypical cells. And those really tell us, I explain to my patients that your cells are doing strange things, but they haven't gotten to the point where we're worried that these cells themselves are going to end up turning into cancer. But that can progress to what's called in situ cancer, which is where you have actual evidence that your cells have the potential to be precancerous, but they haven't shown that they can actually spread out of your body. So that's, you hear a lot about that in situ. DCIS is the most common one, ductal carcinoma in situ. And we hear a lot about that and thinking about how do we treat that and how do we figure out which DCIS could actually become invasive cancer and which in situ stage 0 cancer isn't ever going to be anything. So let's make sure we're not over treating that and putting people through treatment they don't need. And then it progresses to what we think of as invasive cancer, is where the cells have actually shown that they have come out of the ducts themselves, but it doesn't mean that they've spread to the rest of the body. So that's one of the things I think it is so scary to get that pathology call. Again, I've been there myself, and you hear the word invasive cancer and you assume it means that it's spread to the rest of your body. But actually, most breast cancers, when they're diagnosed, haven't spread to the rest of your body, and most breast cancers don't spread to the rest of your body. So I think it's really important to know that just because you hear invasive, it doesn't mean that it's outside of your breast. It just means it has the potential to be outside of your breast. And this is where we can intervene with things like surgery, chemotherapy, hormone blocking therapy, radiation, and really do everything we can to make sure it doesn't spread to the rest of your body in the future.
You know, I think we're going to talk about those sort of myriad of treatments. And I think the personalization of treatment in breast cancer is a really interesting topic as a physician and as a human. I feel that's interesting. We always prognosticate, right? Somebody says, "Doc, what are my chances?" Right? So that means we are trying to give you a prognosis. So what do you take into account when you prognosticate for your patients, when you give them a prognosis for how they will do? What are the factors that you're taking into account when you give them that that sort of game plan or that map to where things are going?
So what's really incredible is it all ties back to that evolution of personalized treatment in breast cancer, which I think is really remarkable. And I always think of myself as I feel so lucky that I got to benefit from that new personalized treatment myself. So there are now tests that we can do that actually test your tumor. And the term for them is called genomic testing, which is a little different than genetic testing, and people often get them confused. But genomic testing is actually testing your tumor for different kinds of genes and factors and putting into an algorithm essentially to tell you what is your risk going to be in the future of this cancer coming back. And I'll use my own story as an example. When being diagnosed at 37 with breast cancer, almost universally 10 years ago, I would have gotten chemotherapy. That was just inherent. Young women, breast cancer, you get chemotherapy. But I was able to benefit from a genomic test of my tumor called an oncotype. And essentially, it showed me that my risk of getting breast cancer elsewhere in my body was very low at 10 years, and that I really didn't need chemotherapy. I could just take hormone blocking therapy, which is a pill I'm on called Tamoxifen that I'm on for 5 years. And it's really incredible to see these curves of how you're going to do long term and help you make the treatment decisions around it. So I would say, honestly, at this point, you know, pretty much all of my patients, both for in situ and for invasive cancer are getting these genomic tests to help them see what their risk is, what their prognosis is, and help them make treatment decisions based on that.
So we actually have a graphic on prognosis, and if we can just pop that up. So it just, do these still factor in, or do you just go right to that genomic testing now?
It's such a great question. And the reality is we use both, and our clinician thoughts, the things of these kind of more like stage and grade and hormone receptors, all of these things go into it for sure. There's talking about age and overall health there. Those things play into account how well you're going to do with certain treatments, and they help us tailor our treatments and help give you a sense of prognosis. I think one thing that, again, I know both Meg and I love to talk about is exercise. And exercise actually plays a dramatic role in reducing the chance of breast cancer coming back. And so I often put into account when I'm giving people their details about their When I'm giving people their details about their breast cancer risk, I always say, right now, this is your time to, if you don't exercise already, start. And if you're already exercising, keep it up, because it truly makes a huge difference in recurrence risk.
We had a question pop in about environmental factors, about food, about environmental pollution. You've mentioned exercise. Meg, maybe you can talk to us about environmental factors that may be contributing to this sort of increased prevalence of breast cancer.
That's certainly for me something that's, sure.
The talc, remember that whole thing about talc?
Mm-hmm.
And also how your deodorant, like they're finding the aluminum or whatever. Anyway, if you go ahead, you finish. All those things just popped in my head. I was like,
oh, absolutely. I mean, those environmental questions are something that, especially for those of us without a strong family history or other pre-indicators maybe of a likelihood or not for breast cancer, we're all thinking about those. We all use deodorant, hopefully. We're thinking about the ingredients and things like that. I will say that for me, all of that came into consideration especially when I thought, wait a second, I already avoid aluminum in my deodorant. I already eat a clean diet and I'm a regular exerciser, and I take supplements that are all supposed to be good for me and helping my body. And I avoid hormones in my meats, and I eat organically. I was already doing so many of those things before I was diagnosed. So then I got even more curious. Okay, well, if I've already kind of, checked off a lot of those boxes, where else did I go wrong? What else happened? Unfortunately, there's not a direct line to try to figure out what caused my cancer. There are all kinds of risk factors. There's clearly a cacophony of things really that build into each individualized health journey. But I will say that after diagnosis and moving through my treatment, I got here to MD Anderson, and I had about 6 weeks left of chemotherapy prior to my surgery. And the physicians here were like, your tumor, the whole situation is just not shrinking at the rate that we want to see it before surgery, meaning that at that point I was confronted with the possibility of maybe not having surgery. And I asked, well, what else can I be doing? I mean, I'm on chemo, but what else can I possibly do to make my body the best situation for this medicine to have its highest level of efficacy? And they put me in touch. They referred me to nutrition, they were wonderful and walked me through, even though I just thought I was doing all the great things with my diet and supplements, walked me through some specific things that I could tweak to make my body an even better environment for chemotherapy to be effective. I didn't realize this. I'm not a doctor, but I didn't know that when you already have cancer, antioxidants aren't your friend because they're trying to protect everything in your body from getting cancer. But if the cancer's already there, they're going to protect that too. I didn't realize that, and I didn't know that. And so I immediately, changed my diet and some of the supplements I was taking to take that into account. Also, upped my exercise and continued to push myself in ways that I felt comfortable, but also just to try to make my body the best possible vessel for the remaining medicine that I had. Who knows exactly how much any of this, what percentage of a role it played in the end result, which was a body that was ready for surgery, which I did go on to have. But still, like Anne said, I am a huge believer that we as patients can't just sit there and have the medicine come in and say, all right, well, it's doing its job. I'm just going to sit here and wait for it to make me better. That's not good enough. We have to do everything that we possibly can to really give our bodies the best chance of taking that medicine and making it have the biggest effect possible. I truly believe for me that that is what got me to surgery. And it was a very intense and complicated surgery that my doctors here have told me really had only, could be handled at a handful of places across the country. But I was able to get to that point because of all of those factors working together. So as Anne said, the medicine is wonderful and it's tailored and it's specific for so many of our own specific cancer experiences. But there are other things that we as patients can be doing to really help that along the way. And I think it's all got to work together.
There's so many great things, and we're going to probably come back and talk a little bit about the diet aspect. But we want to at least bring up this slide on the global incidence of breast cancer, because we do actually have a New York, not in New York, a international show. But this is still some information about women in the U.S. It's 2.8 million breast cancer survivors, right? So, Anne, can we talk a little bit about this? Because getting the diagnosis, as our viewers can clearly see and probably know many breast cancer survivors, it is not the end of it. But in the world, it says every 29 seconds a woman is diagnosed, or a male, and we'll talk about that a little bit. But in the U.S., it's every 2 minutes.
Yeah, so much in that slide. I think that's so important. I'm going to real fast jump in with your comment about male breast cancer, because I think that is a very under-discussed topic. And I know a lot of men going through breast cancer treatment really feel like they don't have the support that those of us going through it as women have. Speaking of, really advocating for yourself. And if you feel a lump as a man, again, that often feels like a difficult place. People think you shouldn't go in. So I would, strongly encourage, especially if you do have a family history, but really for any men who may be feeling breast lumps also, please go in and get them checked out. I think with everything else on that slide, one, as we talked about earlier, this really, it really is something that affects so many people, both in the US and across the globe. But I also love the statistics on that slide about how well most people do who are diagnosed with breast cancer. And one of the first things I tell my patients really at the beginning, kind of before we've even started talking about treatment options, is I tell them, most breast cancer is highly treatable. And there may be more that needs to go into that treatment, whether it's more intensive surgery, whether it's chemotherapy, but most breast cancer is highly treatable. And I know for myself, I kept kind of telling myself that when I got diagnosed, like, what do you tell your patients? That people with stage 1, stage 2, stage 3, earlier stage breast cancers are highly treatable. And honestly, we do a very good job managing metastatic breast cancer these days as well, too. And I think it's so incredibly important that we put more research funding, we spend more energy on really trying to make stage 4 breast cancer less likely and treat it better when it happens. But we really have made such incredible strides in terms of treating breast cancer across the spectrum that I feel very fortunate that if I were going to be diagnosed, it's at this time when we do have such good options for making survival rates really excellent with early stage breast cancer.
We've always discussed the racial and ethnic differences in healthcare, both in diagnosis and in treatment. Sandra Lefkowitz said, what happens if you are a person who does not have the means? And I think, Meg, you addressed that, right? We really want, with this show, with the information available on the internet, with compassionate healthcare providers, nutritionists, exercise specialists in all walks of life to help men and women address the healthcare issues that they are facing, because it is not one and done for almost anything. We have a little graphic there that shows the incidence of breast cancer among different ethnic groups. So you can see that it's higher in white and Black people women in the United States, and lower in Asian, Hispanic, and lower yet in Native American or Alaskan Native people. But it doesn't mean it doesn't happen to those other groups. And I think it's important that we all maintain a level of vigilance. When I put out one of my Facebook posts on this, I said, you know what? It affects 1 in 8 women and a smaller but real percentage of men, but it affects their families and their communities. We want to move on to different types of treatment. We do have a question about tamoxifen, about long-term effects of tamoxifen. Why does somebody get tamoxifen, Anne?
So for a couple of reasons, tamoxifen, its job is to treat or help reduce the risk of getting hormone receptor positive breast cancers. So most breast cancers are hormone receptor positive, which means that either estrogen or progesterone or both are helping kind of feed your getting cancer. So what tamoxifen does is it actually blocks those hormones from acting on your breast cells. So for people who may find out they're at increased risk of breast cancer but don't have breast cancer yet, they may be recommended to take tamoxifen to help reduce the chance. And it actually reduces the chance of getting breast cancer in people who are at high risk by 40 to 50%. We also use it to help treat people who either have stage 0 or have invasive breast cancer that's hormone receptor positive to try to prevent it from coming back both in the breast and in the rest of your body. Tamoxifen is typically recommended to be taken for 5 years, but there are some newer studies and some newer tests that help see if maybe extended treatment, meaning for 10 years, can be helpful. So I see the question here about the side effects of tamoxifen, and I'll tell you it's very varied amongst people. The main ones that we see are things like hot flashes, sleep disturbance. Some people can have some weight gain. Some people can have some mood swings and emotional changes. Certainly for many people, I would say the hot flashes and the sleep disturbances are the major ones. For me, I feel really lucky. As I mentioned, exercise is a huge part of my life. I'm very active. I think it really makes a big difference, both for myself and for my patients, when people are able to exercise regularly. I'm also very careful. I take it in the evening with magnesium, which really helps with sleep. And some people get leg cramps, which has fixed everything for me. So I would say, definitely talk to your doctor if you're thinking about taking tamoxifen for risk reduction or treatment, because we can actually manage most side effects very well, as long as you bring up that you're having them.
Let's talk a little bit, Anne, about, and I think Meg had made mention of it as well, what we mean by when we do surgery on the breast, right? So in Meg's case, she was taking chemotherapy before. We call it neoadjuvant therapy, in case people have ever heard that term. But it really just means sometimes some cancers get treated with chemotherapy first to try and shrink it before you try and take out the cancer. But we have a graphic on what we used to do, and I think we still do, lumpectomy, and sometimes we do an axillary node dissection. You had made mention of that as well, in terms of figuring out which lymph nodes might have disease, and it kind of guides treatment. Are these still being done? And can we just talk a little bit about this slide? And then we also have a slide on mastectomy.
For sure. So I think one of the things that's really neat with lumpectomy that we've seen evolved is actually, rather than putting incisions right over the tumor, we try to hide them. So we try to think about, because breast cancer is so treatable, we try to think about how can we minimize the long-term psychological effects of what we're doing and let people really move past their breast cancer. So when we do lumpectomies, we try to hide scars either around the edge of the areola or along the edges. And then we also, during lumpectomy, actually do something called oncoplastic surgery, which is where we reconstruct the breast using the internal tissue so that people don't have a divot or defect. So I think those have been some huge changes in lumpectomy. It's been done for a long time in Europe, but more recently here, we're really actively doing oncoplastic surgery and hidden scar surgery. And then with the lymph nodes, as I mentioned earlier, we do try to do less lymph node surgery when we can. Some people need to have more lymph nodes removed. And in those cases, we really try, if you are taking most of those lymph nodes that you see in that picture, then we try to really aggressively help people with physical therapy and other stretching and strengthening after surgery to try to minimize the chance that people have long-term side effects like arm swelling and other issues from removing lymph nodes.
A lot of women come in and say, I'm sorry, you can't take my blood pressure on that side because I've had my lymph nodes dissected, or you can't put an IV, an intravenous line on that side. Why is that, Anne?
Well, to be honest, there's no data to support it. So we've really been trying to kind of move past that. I think the concern used to be that if your lymphatics, which help drain fluid and potential infection from your arm, if they're not working as well, because you've had a lot of them removed, you might be more likely to get an infection. And that could be from an IV. The squeezing of the blood pressure cuff could impact your ability to drain, but actually there really aren't any data to support it. So what I tell people is, certainly if you've just had a sentinel lymph node biopsy, only a few lymph nodes removed, I wouldn't worry about it. I think if you've had a full lymph node dissection, if you have the option of using the other arm or using the leg, I think it makes most people feel better. But again, just so everyone knows, there really aren't data that show that you are at increased risk with those non-invasive procedures.
Well, one thing that, if I could, that I'd like to say, I ended up having a double mastectomy. So I had both breasts removed, as well as all 64 of my axillary lymph nodes, 32 on each side. Some were diseased, some were not, but in an aggressive mindset, my doctors opted to remove all of them. Particularly with inflammatory breast cancer, which does involve the skin, there wasn't enough skin left to close me up on my inflammatory side. So as I speak to you now, while I'm wrapping up all of my radiation, I still have an open wound on my left-hand side, which my doctors here closed with a collagen patch, which is something that they had not previously used, even here at MD Anderson, in a radiation setting. But so far, so good. So I say all of that to let you know that, yes, there are women who are walking around you who have had incredibly severe surgery like this, but it is treatable and it is possible. And at these institutions, like the one where I'm fortunate enough to be treated, there are these cutting edge techniques that could really become good options for so many of us who have these non-traditional kinds of cancer diagnoses. So, again, I know that I am fortunate to be able to come here. And I also believe that the next step, when I'm done with all of this, I want to ensure that I'm able to pay that forward in a setting to help more women come to places like this to avail themselves of these techniques. If I had had this surgery at home, at my home hospital, I don't know what would have happened on the left-hand side, because I wouldn't have been able to be closed up in the traditional sense like Ann was just talking about. So again, there are many options out there, but trying to get to them is a different story, and one that I hope to be able to write the next chapter to.
Meg, great points. And I think that is the beauty of medicine nowadays, right? Like that we, because of necessity, new techniques come up. And I think, we've all seen it in our training. And you trained a lot later than Suju and I. So, but we have seen so many great changes. I do want to put up a slide just on staging of breast cancer for our viewers, so you kind of understand what we're talking about. Meg had said she was stage 3. This is sort of, and somebody else had written in about stage 1 disease. And the stage is important. And it's also very interesting to me. And I think Suju and Anne, when you see patients, you can say the same, that when we ask about the patient's breast cancer staging, like if I see somebody, they usually know their stage, and I think it's important because it does impact the treatment and the therapy that you get. Although with genomics now, it's still part of the picture, but maybe the genomics is taking over. It's so exciting, and really that we're at this time in medicine and in breast cancer treatment.
Yeah, it's pretty incredible. And I think, we see people that are stage 3 based on tumor size, but their tumor biology tells us they could be treated more like someone who might have a small stage 1 cancer if it's strongly hormone receptor positive and maybe they don't need chemo. So again, it's incredibly exciting to think about where we've been and where we're going.
We've talked about reconstruction. So we've talked about removing a lump, and then we've talked about removing the entire breast. And there are various things that can be done to reconstruct, to, again, very personalized. I have to say, as a physician outsider looking in, I think the advances in personalization of breast cancer treatment, of breast cancer reconstruction or breast reconstruction are amazing. Can you talk to us a bit about the pros and cons of reconstructive surgery, of staging surgery, and what does it feel like? What does your breast feel like if it's been reconstructed?
We have so many questions, but we also have some slides, so maybe you could talk.
Okay, good. No, that's perfect. So, I think the most important part is what you just said, which is that, it's very personalized, but I think it's also important that people know that this is an option. And you see this, many women unfortunately don't even know that reconstruction is an option at the time of lumpectomy or mastectomy. So these are the kind of things, in my mind, every person when they get diagnosed with breast cancer should get to meet with either a plastic surgeon or a breast surgeon who also does some plastic surgery and reconstruction to make sure they're aware of all of their options. And one of the things we often say is, you don't know what you don't know. And so I think making sure that you're out there and hearing about all the different options beyond support groups, find your community of other people who've been through it to know that maybe there is, like Meg was saying, some kind of reconstruction you wouldn't have thought of. For most women, they actually are able to do reconstruction at the time of mastectomy from a safety standpoint. There are some reasons, whether it's more advanced stage, like in Meg's case, or when people who might need radiation or other reasons to delay it. But honestly, most women can have their reconstruction done at the time of mastectomy. This is typically done either with implants or with flaps, where you use your own tissue from your body and help fill in the space, typically taken from the back or from the belly itself. There are some other flaps as well. I think your question, Suju, about how it feels is so important. So when I was deciding what to do for myself, I had a stage 1 breast cancer, which is highly treatable with a lumpectomy. But honestly, many young women, when they get diagnosed, choose to have double mastectomies. Just to try to kind of reduce the stress and anxiety of screening. But for me, I was really worried about being numb after surgery. And one of my good friends had mastectomies a year or two before I got diagnosed. She says she puts on her sports bra and doesn't feel anything. And so for me, that numbness was really scary. So my husband is a nerve surgeon, and we actually started, our first surgery was a month after my own surgery. We actually came up with a technique to help preserve and reconstruct nerves at the time of implant-based breast reconstruction. So now we're able to look for nerves, we're able to reconstruct them. And so people can actually feel like themselves again after they've had their mastectomy surgery, both with implants and with flap reconstruction, which has been done for a while actually in this country with nerve grafting. So again, for me, I think these are the kind of things, if you ask your team, what do they do? What are the advances? And will you have access to these? Because these are the kind of things, a lot of these people are doing. You just have to find people, and the more patients ask for these kind of advances, the more prevalent they're going to become.
And I will say too, the reason that I found Anne and that we became friends is because I was researching those techniques. I wasn't told by my initial diagnostic team, here's everything that's possible to you, because I was concerned, like many young women are, about sensation and about what that's going to feel like. Unfortunately, it wasn't an option for me, but I'm so glad that she and her team are using that kind of really cutting edge technology for women out there, because that is important and it is part of who we are. And if you want that to be an option for you, go out there and get it.
The numbness thing is so important. Like when you said that your friend puts on the sports bra, if you, patients with diabetes and who have neuropathy, meaning that their feet are numb or they don't feel properly, it's so important, because if you get an injury, you don't know you have it. Like if we scrape something, first of all, I scream high heaven. I like to think I'm tough, but I'm not. But you can't feel it. You don't know that that's an injury, and that is one of many reasons why you want to experience it. I could also imagine if you have that numbness, that it almost feels like it's not part of you, and that no part of your body shouldn't be part of you, right?
Completely agree.
Yeah, what an amazing discussion we've had. I really hope people can use this as a tool to sort of start their journey, or if they're on their journey, to take the journey the direction they want. As we wrap up, maybe we'll ask for some takeaways from our incredible guests. Meg Kinnard from the Associated Press, can you give us a couple of your takeaways for our guests? For our viewers?
Absolutely. Absolutely. The first thing that I would say is we don't know what we don't know. So if you find yourself in a health situation, whether it's breast cancer, another cancer, or something else, do your research, because you're going to be hopefully surrounded by a lot of good health advocates, but you are your own best advocate in every situation. So arm yourself with the information about your own situation, and maybe try to figure out what those other options could be that haven't potentially been voiced to you to begin with. And if you don't see them around you, try to get yourself in a situation where they might be available. I really do feel like this is something that we all should keep in mind. And I very much intend to try to do what I can to make the options that have been available to me an option for more women out there.
Anne?
I love that one so much. I think I would just add, stay positive and stay hopeful, right? You see these slides, again, personally know and professionally how scary a breast cancer diagnosis is, but truly, if it happens, if you're there, get the support that you need, get access to your options and stay hopeful.
I want to thank our guests so much. Again, Meg Kinnard, a politics reporter for the Associated Press, and as well, Dr. Anne Peled, breast and plastic surgeon, co-director of the breast cancer program, and this new novel technique. Wow. Do you feel like, Siju, you and I are just like stuck in the mud? But anyway, thank our team as well. We have a wonderful production team behind each and every episode. Siju, any other final thoughts?
So we'll be back live in 2 weeks. Please let us know what topics you'd like us to cover. And thank you so much for watching and listening.